Hello, my name is Blake Sanford, and I am a third year emergency medicine resident at Ascension St. John Hospital, and I will be presenting my research titled Are Emergency Physicians Able to Predict Which Pediatric Psychiatric Patients Will Require Laboratory Work for Medical Clearance? So, what is medical clearance? In the emergency department, when we have a psychiatric patient present, our goals are to identify and stabilize any non psychiatric medical conditions that may be causing or contributing to the patient's current symptoms, like encephalopathy, delirium, substance use, etc. Our goals are also to identify and stabilize any acute non psychiatric medical illnesses such that the patient may be safely managed at an inpatient psychiatric setting. For instance, if a patient were to have an asthma exacerbation, we would want to treat that first before sending him to an inpatient facility. So many emergency departments, behavioral health services, and accepting mental health facilities require laboratory studies for medical clearance. The American College of Emergency Physicians recommends against routine laboratory testing for medical clearance, yet 80% of adult patients still have medical clearance tests performed. The pediatric body of literature is less robust, but also suggests that screening laboratory testing is low yield for impacting clinical management and is not beneficial over history and physical alone. So essentially, we have a good amount of data, especially on the adult side, suggesting that we may not need to order laboratory tests for every single psychiatric patient that comes into the ER. So, reasons against obtaining these standardized lab studies. So, they can be time consuming, they can be painful and unpleasant for patients and families, especially younger children that require blood draws, which oftentimes require sedation, and there's a lot of screaming and crying. It's just generally an unpleasant process. Additionally, these are costly. So, one study estimated the cost at $1,235 per patient. So, our research question is with what positive and negative predictive values are emergency physicians able to predict whether laboratory studies will impact the management and or disposition for pediatric psychiatric patients in the ED? There have been plenty of retrospective studies done on this, but this is, to our knowledge, the first prospective study in the pediatric population, kind of looking at emergency physicians and whether or not they can adequately predict which patients will need these studies. So the setting is at Ascension St. John Hospital, which is a large academic emergency department with a dedicated pediatric emergency department. So both board certified pediatric emergency medicine physicians and general emergency physicians staff the ED, and there are an estimated 197 pediatric visits annually for psychiatric chief complaints, and this excludes ingestions and suicide attempts. So what is the standardized laboratory panel that we order at St. John? It consists of a complete blood count, basic metabolic panel, a serum ethanol level, and a rapid urine drug screening. If the patient is female, a urine pregnancy test is also ordered. However, that was not included specifically in our metrics because that only incorporates half of the population. So the study design was relatively simple. Emergency physicians staffing the pediatric ER were asked to complete a survey for every pediatric patient less than 18 years old who presented with a psychiatric chief complaint and who had the standardized laboratory panel drawn. So physicians were asked before labs resulted, do you anticipate that the results of these patients' psychiatric lab panel will lead to a change in their management or disposition? And then after the labs resulted, they were asked, did the results change the patient's management or disposition? And surveys were collected from September 1st, 2020 to January 6, 2022. A change in clinical management was defined as either medications given to an abnormal lab result, not including electrolyte replacement if the patient is asymptomatic. So if the patient's potassium is 3.3 and they are given oral potassium but did not have symptoms, and it's an incidental finding, that did not constitute a change. Further laboratory work being ordered due to an abnormal lab result, not including repeating an abnormal result if no intervention is performed. Medical diagnosis, not including drug use as a result of an abnormal lab result, or change in disposition requiring admission to a medical inpatient unit. For instance, if a patient is found to be in diabetic ketoacidosis when they came in with depressed mood and now requires medical admission. So here are the results. So demographics, For the physicians who completed the surveys, we had 21 different physicians fill out a survey. Of them, 13 were male, 8 were female, 5 were pediatric emergency medicine specialists, and 16 were general emergency medicine practitioners. The average age for physicians was 39.8, average number of years in practice was 8.4, and average patient age was 14.2. So a total of 100 surveys were completed by physicians for 100 unique patient encounters. Over on the left-hand side, this is a basic 2x2 table. So is our test of interest asking, do you believe the results of these labs will impact management or disposition? And then over on the top, we have the actual result, whether or not the labs did impact management or disposition. We found that physicians accurately predicted that laboratory results would not alter the management or disposition for patients in 96% of visits. For 4% of the visits, physicians believe that laboratory results would affect the management or disposition. Laboratory studies actually affected the management or disposition in 3% of these visits. And then for all 3 of these visits, physicians were able to predict that the lab results would affect the management or disposition. So our negative predictive value was 100%, meaning that for every time a physician said, no, I do not believe this patient needs labs drawn, that patient did not have their management or disposition altered by laboratory study results. The positive predictive value was also 75%, the sensitivity was 100%, and the specificity was 99%. So the responses to how did clinical management change for the 3 patients who did have their management changed. The first one was possible ingestion but negative Tylenol aspirin, so no further workup needed. The second one was admitted for DKA, and the third one was admitted for toxicology recommendations. Discussing the results of this study, the 3 patients who did have their management changed included 2 ingestions and 1 diabetic ketoacidosis, which, given appropriate history, would necessitate laboratory studies regardless. Emergency physicians, based on the results of this study, are able to determine whether a pediatric patient presenting to the ED with a psychiatric condition will need laboratory testing for medical clearance. Additionally, standardized laboratory studies for pediatric psychiatric patients can be costly, time-consuming, and unpleasant, and they do not appear to provide additional benefit and medical clearance over physician judgment alone. So for institutions that still require mandatory laboratory studies for each psychiatric patient, they may consider removing this requirement. Limitations of the study included the relatively small sample size at 100 surveys. Additionally, we have reason to believe that not every pediatric patient who came to the ED during the study timeframe had a survey completed for them, which may bias the results. Furthermore, 2 physicians completed 70% of all of the surveys. These are pediatric emergency trained physicians who do staff the department the majority of the time, but still, 2 physicians completing the majority of the surveys may bias the results toward the judgment of those 2 physicians. Furthermore, physicians self-reported results, which may have also led to bias. Other laboratory studies, in addition to the standardized panel, may have been ordered. For instance, in a patient presenting with diabetes, a venous blood gas may have been ordered. However, this is not part of the standardized panel, which was our main focus, so this may have altered results as well. Here are my references. Thank you.